Good evening. At the outset, I take this opportunity to thank Vijayanagar Anesthesia Alumni Academics, Professor Dr. S. Balabhaskar, Professor Dr. Srinivasulu, Dr. Parimala, and Dr. Jyotsna ma'am for this opportunity. Today, let us take home some salient points about oxygen transport. Oxygen is the vital element in nature which sustains life. Oxygen delivery and carbon dioxide removal constitutes respiration. Oxygen acts as a terminal electron acceptor in the electron transport chain in aerobic respiration and produces oxidative phosphorylation of ADP to ATP. The tissues rely on a continuous delivery of oxygen for metabolism. Hypoxia leads to anaerobic metabolism, which liberates less energy and production of acids. Oxygen was discovered by Joseph Priestley in 1774 with an atomic weight of 16 and molecular weight of 32. The requirement for oxygen transport is it should be efficient with minimal wastage, should have adequate reserves, and should be able to meet the additional demands. The steps in the oxygen transport are: from the atmosphere, oxygen is taken up to the lungs, and from there it is delivered to the capillaries and transported in the blood, and finally delivered to the tissues where it goes to the mitochondria for aerobic respiration. The four sequential steps in the oxygen transport are the convective mass transport, exchange of air into and out of the alveolar spaces, and the diffusive exchange of oxygen and carbon dioxide between the alveoli and blood in the pulmonary capillaries, the convective mass transport again of blood from the pulmonary to the systemic circulation, and the diffusive exchange of carbon dioxide and oxygen in the systemic capillaries between blood and the tissue cells. The critical link between these mass convective and diffusive movements in the respiratory and systemic circulations is hemoglobin. It amplifies the respiratory gas transport and assures efficient delivery of oxygen to the cells. The process of oxygen moving from the air to the mitochondria, where it is used in aerobic respiration to release energy, is called the oxygen cascade. It involves a gradual decrease in the partial pressure of oxygen from the atmosphere to the mitochondria. As you can see in this diagram, from the dry atmospheric air, through several steps, oxygen partial pressure decreases, and finally when it reaches mitochondria, it is just above 5 millimeters of mercury. The factors which affect these main four stages of the inspired gas partial pressure, the alveolar gas partial pressure, the arterial blood partial pressure, and the cell partial pressure are shown in this diagram. The inspired air is affected by the barometric pressure and the inspired oxygen concentration. The alveolar oxygen is affected by the alveolar ventilation and the oxygen consumption. The blood gas partial pressure of oxygen in the arterial blood is also affected by the scattering of ventilation and perfusion in the lung and the venous admixture. At the cellular level, the partial pressure of oxygen is governed by the blood flow or the cardiac output and the concentration of hemoglobin. In the oxygen cascade, from the atmospheric level of 159 millimeters of mercury partial pressure, through several steps, the oxygen partial pressure comes down to the tissue levels of 33 millimeters of mercury and to the mitochondrial level of 5 millimeters of mercury. Let us see how oxygen undergoes this journey. The inspired air, the atmospheric air has 21% of oxygen. So the oxygen concentration is the 21% in the inspired oxygen. So the pressure exerted by this fraction of oxygen is the partial pressure of oxygen in the inspired gas, or PiO2. It follows the Dalton's law of partial pressures that the total pressure exerted by a mixture of gases is equal to the sum of the partial pressures of each of its constituent gases. So the barometric pressure at sea level is 760 millimeters of mercury, and hence the PiO2 becomes the barometric pressure multiplied by the fractional oxygen inspired concentration. So it becomes 159 millimeters of mercury. From this first step, it is affected by any decrease in the fractional inspired oxygen concentration. and may deliver a hypoxic mixture. If the barometric pressure changes, as in high altitudes, the barometric pressure changes, so correspondingly the PiO2 will also change. Once this atmospheric air enters the airways, in the upper airways it is humidified. At 5 centimeters distal to the trachea, the maximum humidification occurs with pH2O, or the partial pressure of the water vapor H2O 47 millimeters of mercury is added to the inspired air. Hence, the partial pressure of oxygen in the inspired air comes down to 149 millimeters of mercury. The alveolar oxygen partial pressure is affected by the atmospheric pressure, as we have already seen, the inspired oxygen partial pressure, the oxygen consumption, which is quantified by the production of carbon dioxide and the respiratory quotient, and the alveolar ventilation. So it is represented by the alveolar gas equation, where the partial pressure of oxygen in the alveoli is equal to the partial pressure of the oxygen in the inspired gas minus the partial pressure of carbon dioxide divided by the respiratory quotient, which is usually 0.8. So this Comro-alveolar gas equation can be derived as follows. The alveolar partial pressure of oxygen is equal to the inspired oxygen partial pressure minus the oxygen that is already consumed by the body. So it is equal to PiO2 minus VO2. VO2 is quantified by the production of carbon dioxide and the respiratory quotient. Therefore, the alveolar partial pressure of oxygen is equal to the inspired oxygen partial pressure minus the carbon dioxide partial pressure divided by the respiratory quotient. So, the alveolar partial pressure comes down by almost 50 millimeters of mercury from the humidified inspired oxygen or humidified inspired air to about 100 millimeters of mercury. In the post-operative settings, after administration of nitrous oxide anesthesia, the alveolar partial pressure is reduced because of the excessive accumulation of nitrous oxide in the alveoli, because it is highly soluble than the nitrogen, and hence at the end of the anesthesia, the patients may have diffusion hypoxia. The gradient or the alveolar to oxygen partial pressure, this is transmitted by the gas exchange by the passive diffusion across the alveolo-capillary membrane. So this is influenced by the diffusion gradient for oxygen, which is about 60 millimeters of mercury. We know that the alveolar partial pressure is about 104 millimeters of mercury, and the venous or the pulmonary arterial capillary pressure of oxygen is about 40 millimeters of mercury, and hence the diffusion gradient for oxygen is 60 millimeters of mercury. However, carbon dioxide has a very small gradient, 46 millimeters of mercury in the pulmonary arteries and only 40 millimeters of mercury in the alveoli, but it has a faster diffusion, which is 20 times more than oxygen and increased solubility than oxygen. This is governed by the pulmonary capillary transit time, which is about 0.75 seconds. Here, the red blood cells have to traverse the length of the capillary, which is about 600 to 800 microns, and the gases from the alveoli have to traverse the alveolo-capillary membrane, which is the alveolar epithelium, the interstitial space, and the endothelium of the capillaries. So this is about 0.5 to 1 microns. The maximum oxygen transfer occurs in the first 0.25 seconds of this journey, and there is a very good reserve of 0.5 seconds for the pulmonary capillary transit time for additional oxygenation if required, or it can be cut short also. The Fick's law of diffusion governs this diffusion. The particles move from an area of higher concentration to an area of lower concentration at a rate proportional to the difference in their concentrations at steady state. So, the area available, the diffusion coefficient, solubility, molecular weight, as well as the concentration gradient play a part in diffusion of gases from the alveoli to the blood and from the blood to the alveoli. The solubility of a gas in a liquid is governed by the Henry's law of solubility. It is directly proportional to the partial pressure of the gas above the liquid. So higher the partial pressure, there is a chance that the gas will be more soluble in the liquid. There is a difference between the alveolar and arterial partial pressure of oxygen of about 5 to 25 millimeters of mercury. So this is mainly because of the increased alveolar partial pressure of oxygen or the reduced mixed venous partial pressure of oxygen in the veins or the venous admixture. Venous admixture is the calculated amount of the mixed venous blood which would be required to mix with blood draining the ideal alveoli to produce the observed difference between the ideal alveolar oxygen and the arterial oxygen partial pressures. So this can be divided into true shunts, which may be anatomical as well as physiological, and the blood traversing through the low ventilation perfusion ratio alveoli. Normally, venous admixture is less than 5%. After this transfer from the alveoli, the oxygen is transported in the blood in two forms. Dissolved in the plasma, which is less than 2%, but it is significant because it is responsible for the partial pressure of oxygen in the blood. And it is a readily available store of oxygen and mediates between hemoglobin and the tissues for gas exchange. The predominant form, however, is bound to hemoglobin and transported in the blood. The plasma dissolved oxygen depends upon the partial pressure of oxygen, and it is at 0.003 ml of oxygen per millimeter of mercury partial pressure per 100 ml of blood. So in the arterial blood, the partial pressure of oxygen being 100 millimeters of mercury, the oxygen dissolved is 0.3 ml per deciliter. So of the 5000 ml of the total blood volume, 15 ml of dissolved oxygen will be available at an FiO2 of 0.21. Predominantly, oxygen is transported in the blood bound to hemoglobin. Hemoglobin is a tetramer with 2 alpha and 2 beta chains with 4 heme molecules, each with ion at the center. Each heme molecule can associate with one oxygen molecule. The 1 mole of hemoglobin can carry 4 moles of oxygen. So, 64,458 grams of hemoglobin can carry 128 grams of oxygen. As explained by Avogadro's hypothesis, 4 moles of oxygen occupy 89,600 ml of space. Therefore, 64,458 grams of hemoglobin can carry 89,600 ml of oxygen. Thus, 1 gram of hemoglobin can ideally carry 1.39 ml of oxygen, which is called Höffner's coefficient. But practically, the accepted value is 1.34 ml of oxygen per gram of hemoglobin. So, oxygen combines with hemoglobin in 4 stages. First, one molecule gets attached to hemoglobin, followed by the successive attachments of other oxygen molecules. The cooperativity for oxygen binding is expressed in hemoglobin. The interaction of the oxygen molecule with one heme facilitates the binding of additional oxygen molecules to the other heme sites. This is because of the structural transformation of hemoglobin. The oxyhemoglobin attains the relaxed form and has more affinity for oxygen than from the taut form of the hemoglobin. The association or dissociation of oxygen to the hemoglobin is represented in a curve which is sigmoid shaped. It shows the relationship between saturation of hemoglobin with oxygen and the oxygen dissolved in the plasma. So it is a plot of saturation of hemoglobin versus the partial pressure of oxygen in the mixture. So this graph, which is a sigmoid shaped curve, mainly has 3 points: the arterial point, the venous point, and the P50. In the x-axis is the partial pressure, and in the y-axis is the saturation of hemoglobin. At the arterial point, the saturation is almost 97 to 98% represented in the y-axis, and the partial pressure of oxygen is 100 millimeters of mercury. And coming to the venous point, the saturation is about 75%, and the partial pressure of oxygen in the veins is 40 millimeters of mercury. The other 3 y-axes represent the content of oxygen in ml per liter, the supply of oxygen depending on the cardiac output, and the available oxygen. It is worthy to note that the last 200 ml of oxygen cannot be extracted from the hemoglobin because it will lead to structural damage of hemoglobin. The plateau portion of the curve, for a small change of say 20 millimeters of mercury in the partial pressure, there is less change in hemoglobin saturation and less change in the oxygen content of the blood. But the same change of partial pressure from 60 to 40 millimeters of mercury in the steep portion of the curve causes a drastic change in hemoglobin saturation from 19 to 74, and the oxygen content drops by almost 3.4 ml per deciliter. Hence, the plateau portion of the curve is called the association portion of the curve, and the steep portion of the curve is called the dissociation portion of the curve. Another important point in the ODC is the partial pressure of oxygen dissolved in the blood at which hemoglobin is 50% saturated. This is called P50. It is measured at a temperature of 37 degrees centigrade, pH of 7.4, and the carbon dioxide partial pressure of 40 millimeters of mercury. This is a conventional measure of the affinity of hemoglobin for oxygen. The normal P50 for adult hemoglobin is 26.7 millimeters of mercury. Anything less than 27, the ODC is said to be shifted to the left. Anything more than 27, ODC is said to be shifted to the right. The ODC shifts are influenced by the pH, the carbon dioxide, 2,3-DPG, and the temperature. Bohr effect is the one which governs the pH and carbon dioxide influence on the oxygen dissociation curve. The high carbon dioxide levels and low pH decrease the affinity of hemoglobin for oxygen. So at the tissue level, acidemia and high levels of carbon dioxide partial pressure contribute to unloading of oxygen to the tissues. So the pH, any fall in pH, the ODC curve gets shifted to the right, and any alkalosis, the ODC curve gets shifted to the left. The implications of Bohr effect are, it improves oxygenation of blood in the lungs and helps to release oxygen in the tissues. In the lungs, carbon dioxide diffuses out of the blood. Hence, the hydrogen ion levels come down since the ODC curve gets shifted to the left. So it helps in improved oxygen bound to the hemoglobin and increased oxygen available for transport. In the tissues, more and more carbon dioxide enters the blood. So, and the positive hydrogen ions also enter. Hence, less avid binding of oxygen to the hemoglobin and greater oxygen release occurs to the tissues. There is one more effect called the double Bohr effect, where the reciprocal changes in the fetal and maternal sides of placenta affecting the oxygen release to the fetus are shown. From the fetal blood, carbon dioxide and the metabolic end products or acidic end products are shifted to the maternal blood. So this loss of carbon dioxide causes alkalosis and the ODC shifts to the left and it takes up more oxygen from the maternal side. In the maternal blood, because of gain of acid products and carbon dioxide, acidosis occurs, ODC gets shifted to the right and it delivers more and more oxygen to the placenta or the fetus. 2,3-DPG binds to the beta chains of hemoglobin and decreases the oxygen affinity. So the changes due to 2,3-DPG in the ODC are more sustained than due to pH, PCO2 or temperature. 2,3-DPG increases in anemia, congenital heart disease, high altitudes, and any cellular hypoxia or hypoxemia secondary to COPD. In acidosis, septic shock, and in stored blood, 2,3-DPG levels are drastically less. The effect of temperature on ODC, hyperthermia increases the basal metabolic rate and there is an increased demand for oxygen and the ODC curve shifts to the right to meet this demand. Hypothermia may produce the leftward shift of the oxyhemoglobin dissociation curve. Anemia and carbon monoxide can also have an effect on the ODC. It reduces the oxygen carrying capacity in anemia and the oxygen content is also less. But carbon monoxide, which has 250 times more affinity for hemoglobin than oxygen, causes tissue hypoxia and leftward shift of the ODC. And there is a hyperbolic structure to the oxyhemoglobin dissociation curve with the carbon monoxide attaching to the hemoglobin. So carbon monoxide has a drastic effect on the oxyhemoglobin dissociation curve. Coming to the arterial oxygen content. As we already know, oxygen is in the dissolved state as well as bound to hemoglobin. So the sum of oxygen bound to the hemoglobin and dissolved in the plasma together form the arterial oxygen content. So it depends upon the saturation of oxygen with the hemoglobin content, and the partial pressure of oxygen in the blood. So normally it is 28 ml per deciliter of oxygen of blood. The oxygen flux or delivery is the amount of oxygen leaving the left ventricle per minute in the arterial blood. So the arterial oxygen content multiplied by the cardiac output will give the oxygen flux. So as we already know, the arterial oxygen content is about 20 ml per deciliter. And if this is multiplied by the cardiac output of 5000 ml, we get an oxygen flux of 1000 ml per minute, which is the blood, the oxygen carried in the blood, which is going from the left ventricle. So it is as shown in the formula, it is affected by the cardiac output, the hemoglobin concentration, and the oxygenation of the blood. The oxygen which is going to the tissue is consumed by the tissues, and the amount of oxygen extracted by the body in 1 minute can be calculated by Q or cardiac output into oxygen arterial content and the venous content difference. So normally it is about 200 to 300 ml per minute. It is commonly indexed by the patient's body surface area. The normal VO2 index is 110 to 160 ml per minute per square meter body surface area. So the oxygen extraction ratio is the amount of oxygen extracted by the peripheral tissues divided by the amount of oxygen delivered. It is an index of the efficiency of oxygen transport. We know that the oxygen extraction ratio is equal to VO2 divided by DO2, or is equal to SaO2 minus SvO2. So 1000 ml of oxygen is carried from the left ventricle and 750 ml comes back to the right atrium. Hence, the normal oxygen extraction is about 250 ml out of 1000 ml. So it is 25%. So, but it can go up to 70 to 80% in exercise also. The factors which affect the oxygen extraction ratio are the increased demand as during exercise, seizures, shivering, hyperthermia, the decreased cardiac output, anemia, and the low arterial oxygen partial pressures. Oxygen extraction is diminished during peripheral shunting, muscle relaxation, hypothermia, increase in hemoglobin, increased partial pressure of oxygen in the arterial blood, and increase in the cardiac output. Once the oxygen is delivered to the cells, they are utilized constantly by the cells depending upon the metabolic rate. The intracellular partial pressure of oxygen is always less than the interstitial partial pressure of oxygen, and hence oxygen moves from the interstitial spaces to the intracellular spaces. For optimal maintenance of the metabolic pathways, the intracellular PO2 should be ideally more than 3 millimeters of mercury, which takes us to the Pasteur point. It is the critical mitochondrial PO2 below which aerobic metabolism cannot sustain. So normally the Pasteur point is given as 1.4 to 2.3 millimeters of mercury partial pressure. So below which aerobic metabolism stops. The venous oxygen content. After delivering oxygen to the tissues, whatever remains in the blood comes in the veins to the right atrium. So essentially, it contains the hemoglobin bound oxygen and the dissolved oxygen in the venous blood. The 75% saturation of hemoglobin in the venous blood and the 40 millimeters of mercury partial pressure in the venous blood gives us the venous oxygen content of 15.2 ml per deciliter. Thus, the normal venous oxygen content is 750 ml. The arterial venous difference is about 5 volumes per cent. 20 ml per deciliter goes out and 15 ml per deciliter comes in. Hence, the 5 ml is utilized. The factors which increase this difference are cardiac output decreased, oxygen consumption is increased as in exercise, seizure, shivering, or hyperthermia. The factors that decrease this difference are increased cardiac output, muscle relaxation, peripheral shunting, some poisons, and hypothermia. The body doesn't store oxygen except in lungs and the blood. In the lungs, the FRC and the alveolar oxygen concentrations are important oxygen stores. Therefore, the pre-oxygenation or denitrogenation with 100% oxygen inspired for 3 minutes helps to fill the FRC with oxygen and increases the store of blood during the periods of apnea. This is the concept behind our pre-oxygenation. In critical illness, the oxygen delivery is affected and tissue hypoxemia occurs mainly because of the altered regional distribution of the blood flow. The endothelial damage, microthrombosis of the capillaries, and the neutrophil activation and the inflammatory response also affect the oxygen delivery and the intake of oxygen. Our anesthesia also affects the oxygen delivery. Most of our anesthetic drugs are respiratory depressants and they suppress the normal protective response to hypoxia. During induction of anesthesia, there is a gradual decrease in the functional residual capacity. The ventilation perfusion matching is there is a disparity after induction and paralysis during anesthesia. Atelectasis changes are more common under anesthesia. The venous admixture and shunting also can be more under anesthesia. The hypoxic pulmonary vasoconstriction may be suppressed under anesthetic drugs. There is a decreased cardiac output and decreased oxygen delivery under anesthesia, but simultaneously the metabolism is also suppressed during anesthesia and the work of breathing is also less if the breathing is taken over by controlled ventilation. Thus, oxygen transport physiologies we have seen so far can explain the different types of hypoxia. The changes in the inspired oxygen partial pressure, the inspired oxygen fractional concentration, the changes in barometric pressure, alveolar ventilation, diffusion, and the oxygen flux venous admixture can explain the hypoxic hypoxia, where the oxygen delivered to the lungs itself is lower. In anemic hypoxia, either the oxygen carrying capacity is reduced because of anemia or because of carbon monoxide poisoning or different forms of hemoglobin in the blood. This stagnant hypoxia results when the cardiac output or the regional blood flow are decreased. When the mitochondria cannot utilize oxygen in their metabolism, then as in cyanide poisoning, then the histotoxic hypoxia occurs. And the low P50 hypoxia occurs when the pH is increased, there is hypothermia, and the 2,3-DPG levels come down. So these physiological principles of oxygen transport explain the different types of hypoxia that are possible. The postoperative hypoxia which we encounter may be because of the diffusion hypoxia after nitrous oxide anesthesia, increased mismatch between the ventilation and perfusion, maybe because of the atelectatic changes or increased shunt fractions, the reduced cardiac output because of the depressive effects of anesthetics on the myocardium, on the circulation, or the hypoventilation because of the drugs, obstruction, pain, and the intraoperative hyperventilation. Hence, the take-home message is the oxygen transport from the atmosphere to the cellular level occurs in a cascade. This involves a complex interplay of the physical principles and the coordination of the cardiorespiratory systems for maximum efficiency and safety during the delivery of oxygen and removal of carbon dioxide. Understanding the oxygen transport is very useful to interpret different clinical situations in anesthesia practice. Thank you.